Hi, welcome. I'm just going to wait for my colleague for just a minute or so before we get started. Hi, welcome. We'll get started very shortly. Oh, lots of people. Welcome, everybody. I'm just going to link up with Charles Kingsland. Won't be a second. It's 1 o'clock now. Welcome. Rosie Posey. Oh, Jackie's there. Hi. I'm just going to hook up with a colleague, Charles Kingsland, and then we'll get started. I'm Alison Campbell. I'm the Group Director of Embryology for Fertility. And we've got a nice Instagram Live today to talk you through all sorts of questions that have come through. We're going to be looking at how to choose a fertility clinic during the COVID-19 pandemic. So I'm just waiting for Charles, but I can start without him. He'll be along shortly, I'm certain. So there are loads of things that need to be considered as a patient when you're choosing a clinic. And probably more so during this pandemic. Times are strange, obviously, and lots of considerations that need to be gone through. So we're going to be discussing these factors, myself with Charles Kingsland. He's the Group Medical Director for Care Fertility. He's also the Medical Director of our Liverpool clinic. So he'll be here shortly, and we're going to be able to ask him loads of questions. He's been in this field for such a long time. He knows so much. He's a font of all knowledge, and he can play the piano. So I know that he's sitting beside his piano, and I'm hoping that we might get to hear him maybe at the end of the Instagram Live, just a little tune. So we could start by looking at success rates. I'm just trying to find him because I don't want to do it on my own. Let's see. No, I'm happy to do it on my own. I will. Okay, I don't see him just yet. But anyway, so we talk about success rates. Very important and a key factor when patients are looking at where they're going to put their trust and where they're going to have their fertility investigations and potential treatment. So the HFEA website is a great resource. It shows all the clinics across the UK, all their verified, validated data, their results broken down by age. And this is a really good place to start, I would say. But there are limitations in looking at historical results. And of course, on the HFEA website, the data that's presented are a couple of years out of date because it takes that time to get the live birth outcomes, to do the validation process and to get those published. And clinics are improving all the time. They're making changes to practice. They're fine-tuning their protocols. And so I think it's always important to contact clinics directly and talk to them about their success rates, and especially their success rates for patients like you with a particular fertility issue or medical history. Your age makes a massive difference. So all of these things need to be considered. And so talking to the professionals about your own situation is very important when considering success rates. Other considerations as well around beyond success rates, which are very important obviously, are what treatment types are offered in the clinics that you're considering having your treatment at. Maybe donation of eggs or sperm is required. So we need to consider which clinic offers that, and do they have a good programme? Is it well established? What are the success rates like with donated eggs or sperm in their hands? We also need to think about geography. I think it's a stressful time for many patients undergoing fertility treatment. So if you can go to a clinic close by I think that could take a lot of burden off if you're travelling long distances. I mean, we know many patients actually travel overseas. So all of those things need to be considered because they can put an additional emotional and financial burden on patients when they're choosing where to go and have their treatment. So we've had a question here from a patient saying, when I look at IVF clinic websites, there's so many different success rates, so which ones do I look at? Well, my advice would be look at the treatment, look at the results that relate to the treatment that you expect you will need, but accepting that some patients probably at this early stage in their journey may not know which treatment they need, so that can be a difficult one. But if you know which treatment you need, then you could focus in and look at those success rates for your specific treatment. You can look at live birth rates and you can look at clinical pregnancy rates. So the difference, we know a live birth rate is the baby's been born, the data will be more historical than a clinical pregnancy rate. And a clinical pregnancy rate means that the embryo transfer has been performed, they've had a positive pregnancy test, and a fetal heartbeat's been detected on an ultrasound scan. So that's fantastic. That's what we're looking for, the fetal heartbeat. And those results are going to be more current than a live birth rate. So you can take both of those into account and see how you feel about that. But it's important to consider both, I would say, but bearing in mind the limitations of them. Now, success rates are often quite similar between clinics, so you might want to consider whether the clinic that you're considering does personalised treatments. How personalised? How much time will they spend with you to talk about your situation? What investigations will they undertake? And do you like the feel of the clinic? You can go and have a look around. I mean, these days with the COVID pandemic, not so easy, but many clinics will offer a virtual tour. And lots of online interaction. So I think those sorts of things are very useful tools to help you choose your clinic. I'm going to see if Charles is here yet. Nope. Let's see. I'll go live with, I can try and find him on here. He was logged on just a little while ago, but nope. I could go live with somebody else, but that might not be. No. So personalised treatment, obviously important. Every patient's different. There are different medical needs, different wishes, and patients need to have a personalised treatment. And I would say at Care Fertility, we do offer that, definitely. And we also, if we're thinking about geography, we have 12 clinics across the UK and Ireland. So there probably is a care clinic quite close to you, and we'd love to see you if you want to come and talk to us. We can offer consultations straight away. We just need to contact your local care clinic and we can arrange that. We are offering some one-to-one, face-to-face consultations, but we are strongly encouraging online consultations at this time, which I'm sure you will understand why. When you talk to your clinic, you must ask them how much time you have with the consultant, with nurses, and talk about different protocols, because we had a question about how standardised are clinical protocols. So when you get a prescription, would you get the same prescription as somebody else, or do we genuinely personalise them to make sure they're right for you? And of course, in our hands, we absolutely would consider your circumstances, your age, whether you've had previous treatments, your body mass, the risk of ovarian hyperstimulation syndrome. It may sound like jargon, but it's a very important consideration. It's a side effect, a very rare side effect of fertility treatment, but we need to avoid it. So absolutely, these clinical protocols are devised individually to get the best response that we can safely for each patient and avoiding the risks. So that was a question from Siana. And how much do you tailor each person's treatment? Does everyone get the same dose of medication? Well, they don't. We do absolutely tailor. Do we offer mild IVF to prevent this ovarian hyperstimulation syndrome? And do we focus on the quality of the eggs rather than the quantity of the eggs? So yes, we will do the stimulation as mildly as we can in order to get a good number of eggs to provide the best possible chance of getting a blastocyst transfer, an embryo transfer, to give you a good chance of treatment. Monitoring very carefully all of the way. We can make modifications as we go along if necessary. And if we get an unexpected high response to the medication and we think there's a risk of ovarian hyperstimulation, then we can talk about freezing the embryos rather than doing a fresh transfer, which will substantially reduce the risk of this syndrome. And freezing embryos is absolutely well established, nothing to be worried about. We get phenomenal success rates with frozen embryos. So throughout 2019, so our most current and large period of analysis, we achieved 99% survival of all frozen thawed embryos, blastocysts. So they survive beautifully and they implant at least at the same rate as fresh embryos. So I'm sure it could be quite disappointing and daunting if you're in the middle of your fertility treatment and you're told we need to freeze your embryos for your own safety. You might be disappointed, absolutely, but please be reassured it's a very well established and successful procedure. Our laboratories are very sophisticated methods. Our embryologists are very experienced at vitrification, the freezing technique that we use, and if it's the right thing to do, then we would talk to you about doing that. Some more questions flying in. So we've talked about online consultations, I've mentioned that, and communication. So some questions around how to get in touch. Will we keep in touch with you if you're existing patients? Should you contact us? What if you're a new patient? Can I have a nurse appointment? How up to date is the website? So if I just cover all of these things, generally, we are contacting patients. We have been for the last few weeks since we submitted our self-assessment questionnaire, and were given the green light from our regulator to resume fertility treatments. So since then we've been contacting patients that had started their treatment before this pandemic, or were in touch with us and wanted to get started. So we've been contacting patients in the system, getting them started again, and we've got new patients who want treatment, and that's great. So we are ready. We are offering consultations now. If you haven't heard from us and you're expecting to, then just get in touch with your local care clinic or ring the general inquiry number, and that's on the website, and we'll get back to you and sort something out, get an appointment arranged. We do also offer nurse appointments, consultations. A lot of the teaching that we might have done previously face-to-face, we can do with online tuition methods. We've got some wonderful videos just to teach you how to administer the injections that you require during treatment. But we are there absolutely to support. It's a little bit different than it was before, of course, but still offering as much support and guidance during your treatment as we possibly can. We are updating our website regularly, keeping in touch with everyone. We have a wonderful system, the patient portal, so we can push information, documents, consent forms into the patient's portal so that they flash up and keep you informed at every step of the way. We do some electronic consenting as well, so this is all reducing the number of visits to the clinic and making everything more streamlined. So it's working really well. And there's a question here about protocols. We'll come back to that. Oh, it's someone, Rosie Posey, is hoping that Charles is making coffees. Yeah, I hope so. I wonder where he is. Okay, he's here. Let's see. He's here. Right, we're going to find him. There we are. He's changed his name. That's fine. Let's see. Where's Charles? Charles is coming. He's connecting. That's fantastic. So this is Professor Charles Kingsland.
Hello.
Here we go. Hi, Charles. Welcome. We're just loading you in, I think. Yeah, it's a little bit slow. Yeah, I can hear you, but can't see you properly yet. But we'll. He's probably been. There we are. There we are. Hi, welcome, Charles.
Just, thank you. Sorry, I'm a bit late.
Oh, good. Welcome.
Yeah.
Were you listening in anyway?
It was very good. Very interesting.
Did I get anything wrong?
No, you didn't.
Oh, thanks.
Distinction.
Oh, that's kind. Yeah. Thank you. So, great. Well, Charles is, somebody says, poor Alison. This always happens to you. I know. It's fine.
I'm really sorry. I didn't do it. I certainly didn't do it.
No, I know. You wouldn't do it on purpose. I know. And we practiced and it was fine.
Yeah, that's right.
So Charles is the Group Medical Director for Fertility. He's a professor. He's a font of all knowledge. And I'm so pleased that he's here. So Charles, there's a question just came up about long and short protocols. So could you just talk us through the differences and what might be the best recommendation at this time?
Yeah, the difference in short and long protocols is we just use a slightly different drug. The importance of the stimulation part of your IVF is that we dampen down your own hormones just for the time that you're having your stimulation. So your hormones don't get in the way of ours, so they don't set off any adverse reactions. Now, there are two types of down regulation. There's the long down regulation, where we give you a big dose for a long time to sort of put your own hormones to sleep and then wake them up at a later stage. Or there's the short protocol, where we allow your hormones to take part in our stimulation, but just every so off, we just switch them off temporarily, and that shortens it shortens the time that you're being stimulated. There is no real consensus to which one is best. The short protocol obviously is shorter. I would say that probably on balance most people prefer that, and there is some suggestion that there is a lower risk of hyperstimulation syndrome with the short protocol. Nevertheless, some doctors have a lot of experience with long protocols, and they find it more successful in their hands. So really it's the choice of the clinic and the choice of the clinician, and obviously you have a choice as well as the patient as to what you think is best for you, but generally they're much of a muchness, and the clinicians have their own individual preferences. So don't feel as though just because you go to one clinic they offer a short protocol it's going to be better. It's not. They're just slight variations on the same sort of theme.
Yeah, and we were talking before. Yeah, we were talking about personalised medicine, so it's a good example. We consider each individual case.
Yeah.
So there's a nice question here about Liverpool. So what's the situation with Care Liverpool? How can this patient get in touch?
Oh, well, Care Liverpool is now open. We're the safety of patients and staff is paramount at this time of this pandemic. But we have felt on balance that we can open Liverpool and often offer face-to-face consultations. Why? Because the clinic is relatively small. We can manage the patient flow through the clinic very successfully whilst maintaining social distancing, and so we're confident that patient safety and staff safety has been maintained. So the clinic is opened. It's been open for a week now, and we're offering face-to-face consultations. Interestingly, at this time, Ali, a lot of patients have preferred the telephone consultations. So across Care, I think we're offering, depending on how we can put together the social distancing protocols, we're offering both face-to-face and telephone consultations. At Liverpool, you have a choice. You can either come and see the doctor, i.e. me at the moment, face-to-face, or alternatively, you can request a telephone consultation if you find that more convenient or preferable. To get in contact with us, you can either get through to our central line, which is GEM, or you can phone the Manchester number, or you can alternatively phone direct to the Liverpool clinic. And you're going to ask me what number it is now, and I can't
Well,
remember.
those numbers are on the website. Yeah,
it's quite.
Yeah. That's
So
fine.
I look forward to seeing, and it's actually quite nice at the moment because the one thing, going back to personalised medicine, Ali, that we put a lot of emphasis on in care is to give patients the time. I think it's a valuable commodity, and when you're going through what is already a stressful situation, and then it's compounded by the current viral problem, I think it's nice for patients to know that we've got time for them. And that's what care prides itself on, that even if you think you've got questions that might to other people seem a bit trivial or silly, to you they're important, and to us therefore they're important. And that's why this personalized medicine and the time for you to get your messages across is so important, not only to you but to us as well.
Yeah, brilliant. We've got a question that's probably for a virologist, but I think you might be able to answer it. So it's from Sarah. She's been told that she needs to test negative for COVID 4 weeks after testing positive to be able to restart her treatment. But she's concerned because she's worried that she might still test positive due to dead viral cells, and not, even though she's not contagious, she thinks that it might still be in the system and give a false positive, I guess.
Well, this is all to do with the test itself, and with tests, they're not 100%. But the one thing that we do know about this, the test for COVID, is that up to 30% of patients who have the disease or have had the disease will test negative. Okay, and that's why there's a lot of controversy about whether we should be testing everybody or not, because 30% of the patients that have had the disease will still test negative. And it might be because the test has been done at a time when when the virus is in low numbers, or you've had the disease and the virus levels are coming down. But one thing about the test is that if you are if you are positive and you got it, and you have had a positive test, it will still show up. It will show up negative when it's negative. So, and this is the idea why we want to wait for 28 days. Why 28 days? Who knows? That's the scientific advice at the moment. It's the best advice we've got. So really, if you've had the disorder, we would want you to wait 28 days and then test again to ensure that you are negative. But if the viral load has come down to a certain level, it will be negative. Okay, so let me just reassure you on that. And I think actually, just using one's common sense, 28 days seems like a sensible time to get it out of your system, to get over the disorder, and then you'll be in the best physical and psychological state to get going again. Is that okay?
Yeah,
does that
that's a good answer.
Yeah.
I think that's reassuring. Yeah, I think so. We've got loads of questions, so we're going to quick fire.
Yeah, okay.
Quick fire. What about satellites? No, we've got lots of satellite clinics. I said before, we've got 12 main clinics with laboratories where we do the actual treatment, but we've got a lot of satellite clinics, and some of them are in NHS hospitals. So patients are asking, well, are they open? Can they come through the satellites? And what can we say about that, Charles?
Well, I have a lot of sympathy for the NHS because they've borne the brunt of the virus. There are still a lot of ill patients in the NHS or in NHS clinics, and of course the NHS hospitals have now got to start thinking about how they start the service, and that's across the board, not only for fertility, but also cancer and general surgery and all those sort of things. So for us in the independent sector, generally we can maneuver quite quickly, which is not the case in the NHS sector. So I think it's understandable that NHS hospitals are going to take a lot longer to get up and running again safely than say Fertility can. And I have an NHS contract. I work in an NHS hospital, and I was at a meeting just this week, and it really is very, very difficult to get all services up and running very quickly. So unfortunately, for the majority of NHS patients, you're going to have to wait a little bit longer to get your treatment, and there's precious little we can do about that. But the good news is that hopefully within the next 8 to 12 weeks, things will be resembling normality again for the National Health Service. But for us, for care, we can move a lot quicker.
Yeah, great. So I thought if I just quickly talk about the lab for a couple of minutes, and then we'll come on to steroids. That's a hot topic. So just to let everybody know what we're doing differently in the lab. And to be fair, we've not made huge changes because we didn't have to, because we're already very familiar with infection control, working in a very clean, sterile environment, wearing personal protective equipment. We already wear hats. We cover our hands with gloves for certain procedures. So we've added masks in, really just to protect each other from each other. We work in flow hoods, workstations where the air is circulated and filtered. So the environment is very special already. And if we think we're putting a barrier in place for patients and staff to even enter the clinics, so we're reducing the footfall, we're checking, doing health checks before patients come in and staff come into the clinics. So that's the first barrier. And then before anybody goes into the lab, there's another barrier. So it's restricted entry, particular clothing. The air is filtered inside the lab. The air inside the incubators has another level of filtration. So lots of already lots in place to make sure it's a very safe environment, of course. So we have changed a few things, but we didn't have to make substantial changes to deal with treatment during this time, which is, I think, reassuring to know. One thing that we've introduced, which was already in the planning phases, so we've speeded it along because it really sits well with the current situation, is a do not disturb practice. So very briefly, we offer two types of treatment in our laboratories. So we have the time-lapse system, monitoring continuously. We've got algorithms, models that help us choose the best embryo, called care maps. So we have that system, and we also have a more standard incubation system where we don't take photographs, and we're reliant on embryologists' assessments of embryos. And traditionally, those dishes with the embryos in are moved from the incubators most days for a quick check. But what we've learned from our time-lapse experience and care maps is that we gain very little information from taking the dishes out of the incubator every day. We have a couple of minutes to look at them, write down what we see and put them back, because it's not good to bring them outside of the incubator too much. So we're doing many less observations in our standard system. So we call it do not disturb. We let the embryos develop, and then we assess them only when we need to. So that's something new that for existing patients that might they might want more information, and we've got very detailed information, and we're happy to discuss it in more detail. But we think it's a very positive move. So should we talk about steroids and immune therapy?
This is a very contentious subject, and the whole theory about using immunosuppressants in IVF is that when the embryo goes back, you use these suppressants to reduce the immune response of your body against the embryo. And the idea is that if you suppress the immune response, then there's a higher chance that this little foreign body, the new embryo, will implant. You know, whether you approve of that or agree with that, that's the theory behind it, and it's met with a lot of success, although the jury is still out as to whether it is of unequivocal benefit. However, in these times, in theory, if you suppress the immune system at a time when you could get a potentially nasty new virus, your body will not be in a position to fight the virus. And so, in theory, the virus will have a more severe effect on the person who is immune suppressed. So this is why people have been isolated and have been secluded in their own homes if they've got an if they're on immunosuppressants for other conditions, maybe for cancer or rheumatoid arthritis or things like that, where you want to suppress the immune response to stop it attacking the body. So at this particular time, it wouldn't be safe, in theory, to offer immunosuppressants to try and improve implantation of embryos, because if you get the disease, then in theory, you could be a lot worse off. So for the time being, the use of immunosuppressants in IVF is absolutely contraindicated, and I would agree with that. It's not in anybody's interest at this moment to use immunosuppressants. Now, of course, that may change, and as soon as the virus is out of the community or we've got a vaccine, then that might be different. However, if your doctor has prescribed you immunosuppressants, or you've been successful with immunosuppressants in the past, there is no reason, as Ali mentioned before, that you couldn't have your embryos created and then frozen, and then we could keep them safely in our laboratory until such time as we are able to use immunosuppressants again, so the embryo can be thawed, you can have your immunosuppressant therapy and have those embryos put back in an environment that is safer for you, so that if these immunosuppressants do have an effect on your general well-being, you're not going to run the risk of being infected more severely by COVID-19. So hang on. And as Ali said, freezing embryos, I think, is a really good deal these days. It's not like it was 20 years ago. The success rates of freezing and thawing embryos are every bit as good, if not even better than they used to be, than fresh embryos.
Yeah, brilliant. So I think we've probably got about 5 more minutes. There's a question about waiting lists, which I think is asking that if we receive an NHS referral, would it mean that they would still have to wait longer than a private patient will? No, absolutely not. Once we've got a referral, we get on with treatment when you're ready. It's straightforward. And question about egg donation. So are we still recruiting donors? And what's the situation with egg donation? So yes, we are are recruiting donors still, eggs and sperm donors, and we're launching a new egg bank very soon, imminently. We have lots of frozen eggs, and we're just as experienced now with egg freezing as we talked about embryo freezing. It's a very similar technique, so we will be launching that very soon. Our donation teams are back and working hard to get everything in place. So that's
this is yeah. I was just sorry for interrupting, Ali. This is from a clinician's point of view. This is really exciting about care. Now we've got the egg bank, and what is really encouraging is that the results for frozen eggs is now every bit as good as fresh eggs. Is that not right, Ali?
Yeah, almost identical. Yeah. And there are benefits as well, because the wait for treatment is much shorter with the frozen eggs, because with the fresh treatment we have to synchronize the cycles with the donor and the recipient. It takes a bit longer to find the right match, whereas with the egg bank we have all of the eggs there. We've recruited these donors ourselves, and we've been freezing them and banking them for some time now, and we're ready to release them to match. So there's more choice as well. So it's a wonderful thing.
Yeah, having an egg bank is great. I think it's great for care and great for our patients to have this facility available. It's going to really move things along very, very, very encouragingly.
Yeah. Oh, we've got a question from Claire about the Do Not Disturb policy. So she's already seen it on the website. So we're making everybody aware of it. So yes, it means we won't be looking at the embryos every day. We don't believe we need to, and we are based this on our own experience and evidence from the time lapse. So we know what we'd like to see, but taking the dish out to look at them once a day, it's chance whether we see what we need to see, because the embryos, obviously it's dynamic, it's changing all the time. So it's not really adding much value. And we believe that leaving them in the undisturbed environment, perfect temperature, perfect gas mixture, is going to give them more benefits than removing them and making the assessments. So that's where we are,
So
and we're really pleased.
We won't
Sorry,
need as
Charles.
many embryologists then. We won't need as many embryologists. What will you do with your time?
No, we'll be... No. Well, we'll be analysing the data. We'll be fine-tuning our practice. We'll be checking all our equipment. We'll be spending more time with patients, doing research and development. It's not going to save us. It's not about time saving, obviously. It's about continuous improvement.
I think that the concept of being able to leave the embryos undisturbed yet still monitoring them, I think it just intuitively feels right, doesn't it? It's really that's a really great innovation.
Yeah, well, CareMaps offers everything. Yes, the undisturbed culture and the continuous monitoring and the advanced selection. So it's a phenomenal culture environment for the embryos to develop the best possible way. And it's evidence-based. So it actually, our algorithms predict the chance of live birth. So we can choose the best embryo first time and enhance results. So it's great.
I think, you know, I've been at Care for a few years, and you have, Ali, but that having worked in other units for many years. But CareMaps is a really impressive innovation, and I've been very impressed with how we can pick our embryos so accurately nowadays by the use of CareMaps.
Yeah, and well, breaking news, we are about to launch the next version. So we don't just build a model and then we use it forever. We get more data, get more experience, and we keep fine-tuning. And over the next few weeks, we're going to be launching an even better, more accurate selection model by CareMaps. So
how many embryos is that based on?
Well, it's based on 8,000 transferred embryos with live birth data, and about 12,000 embryos with fetal heartbeat data. So it's massive, world-class data set. It's phenomenal. Hopeful Alice says it's amazing. Oh, that's nice. Well, it is amazing. It is amazing stuff. But I need to say, Charles, you have got a fan club. Lots of patients say they know you from years gone by, and all the messages coming in. It's nice.
That's very nice to know. And do you know what? It's great to be able to be up and running again, and just seeing patients face to face is you know, for the certainly in Liverpool for the majority of patients, that's it's nice for them. I'm not saying that as I said before, telephone consultations seem to be effective, but if patients have got, you know, to give them that option, that if we can safely see them in a safe environment, then you know, it's nice to have that option available to them.
Yeah, so I think we need to start tying it up, but we haven't mentioned PGTA, which is a hot topic, and there's a question here from JSN. So they had embryos in the last treatment, but they were all abnormal. So I mean, it might be that morphologically, so the shape of them was abnormal, or it might be they had genetic testing and they were abnormal. So I'm assuming it's the latter. But about to start second round, is there hope for a normal embryo?
Well, that, of course, that depends on a lot of factors: age, ovarian reserve, how many eggs you got last time, what were the sort of abnormalities. And I'm sure that before you embark on your next cycle, you'll have seen, your consultant, who will have gone through what's happened in the past very, very carefully, so as to predict for you what might happen for your next cycle. And if that happened, what I would encourage you to do is to make sure that you're fully informed about your chances of going through the same cycle again, and what your chances of success are for you, because it's important that before you embark on another very stressful and maybe expensive round of treatment, you are informed, and you are well informed about what the likely outcomes are. And of course, there's always hope. There is always hope.
Yeah, that's exactly it. Yeah. So I think we should round up now, Charles, but we've had loads of questions, and we'll try and get back to everybody if we can with responses. And we'll be back soon, I imagine, and I hope it's been helpful. It's a difficult time, but I think the sun's just come out. That's a good sign. I think we're turning a corner, aren't we? And we are all here to help. We want to get back to normal as soon as we can.
And it's not it's not long. It's not long before we'll be back to normal, and we'll be better and brighter because of all the things that we've learned from this pandemic. We've had time to reflect, so things are looking really good for the future. Yeah.
Are you going to play us out on the piano? I know there's one there. It's a little bit silly, but
well, I was going to, yes, because this was the only stand I could get my phone on. But anyway, yes, I'll probably leave it at that for the time being. But next time, lovely. I'll practice something.
Great.
Bye,
Thanks,
Ali.
Charles. Thanks everybody for joining us. See you soon. Thanks. Bye. Bye.